All right, we'll go ahead and get started. Thank you, everybody, for being here, the last session of the day. My name is Lisa Chow. I'm an endocrinologist from the University of Minnesota and an associate editor for diabetes. This is a topic that's actually sponsored by the Journal of Diabetes, From Quantity to Quality, I think as it relates to weight loss. I think they were missing a few words. At any rate, we have an illustrious group presenting today. Our first speaker is Dr. Mary Ellen Harper, who's a professor of medicine from the University of Ottawa and director of the University of Ottawa Institute for Systems Biology. Her research focuses on the metabolic efficiency with an emphasis on mitochondrial processes, particularly in skeletal muscle. She's especially interested in mitochondrial energetics, specifically the mechanisms that impact the efficiency of energy transduction pathways. She holds a Tier 1 Canada Research Chair from the Mitochondrial Bioenergetics and Metabolic Health, which is the top tier for Canada Research Chairs programs designed to attract and retain world-class researchers at Canadian universities. Her research is also funded by the Canadian Institutes of Health Research and the Natural Sciences and Engineering Research Council. In 2021, she was awarded the Lifetime Achievement Award from Diabetes Canada. Please join me in welcoming her.
Thank you very much, Lisa, and thanks for the invitation to participate in this symposium. It's a real great honor and pleasure. As Dr. Chow was saying, my laboratory at the University of Ottawa is a mitochondrial bioenergetics lab, and we're most interested in how the efficiency of energy transduction in cells and tissues and hopefully the whole body varies from person to person. So inter-individual variability is a big focus of our research. So this is a long-standing collaboration. These are my clinical colleagues, and what I'll be talking about today. We do research in mice and cells and also in human translational studies in collaboration with my clinician colleagues, Ruth McPherson, who's a geneticist at the Ottawa Hospital, Ottawa Heart Institute, and Bob Dent, who's been the director of the weight management program at the Ottawa Hospital. And I've been working with them for over 25 years on these questions about fuel transduction efficiency with the focus on skeletal muscle. And the observation that we've been so interested in for so many years is that individuals in this controlled weight management program, meal replacement program, OptiFast, very low calorie, 900 kilocalories a day, varies 2 to 3-fold after you control for all factors known to affect weight loss. So these are, this is in the diet adherent subpopulation of patients, and you can see on the right-hand side this, let's see if I can get the mouse to work. Over here, you can see the uppermost quintile for rate of weight loss at 6 weeks and the lowermost quintile for rate of weight loss at 6 weeks. And then we recruit these extremes for response and then study their muscle and look at differences in efficiency in muscle metabolism and so forth. And you can see the differences in these two groups, the differences in the trajectories of weight loss over this clinically managed program at the Ottawa Hospital. And again, weight loss varies 2 to 3-fold, matched for age, sex, initial body weight, absence of known factors affecting weight loss, medications, mobility, disease, thyroid hormone status, and so forth. So we've been looking at mechanisms that might help to explain, biological mechanisms that might help to explain these differences. Now, inter-individual variability in response to obesity therapies goes beyond response to diet, but also has been observed and written about by researchers in that area. Donna Ryan and Ken Fujioka, for example, have been writing about inter-individual variability in response. Obviously, it's very complex, but it's something worth investigating for personalized therapies. Similarly, in surgical approaches for the treatment of obesity, you can see the inter-individual variability in the histogram in the bottom right there. These data are from Lee Kaplan's group at Mass General Hospital, and you can see the substantial inter-individual variability there. So we've been focused on skeletal muscle and differences in mitochondrial energetics, mitochondrial content, fiber type, and so forth. And what we typically do is take a biopsy from the vastus lateralis, usually, and with a relatively small biopsy size, 150 or so milligrams, with a Bergstrom needle biopsy, you can do a wide range of determinations, as shown down in the bottom left there: immunohistochemistry, primary cell isolation, etc. And so, using these approaches over the years, we've found that greater weight loss or dietary responsiveness or fast losers in these populations are associated in their skeletal muscle is associated with higher type 1 oxidative fiber content in proportions in the muscle, higher levels of mitochondrial OXPHOS transcripts, higher level of fatty acid oxidation capacity. When we take the myofibers shown in the top right photograph here and study them with high resolution respirometry, we see higher fatty acid oxidation capacity in their muscle. And this is something that we've pursued many times over the years in different populations. We see higher leak uncoupling in mitochondria. When we isolate mitochondria from the muscle, study those isolated mitochondria, and then in another study we studied amount of leak in permeabilized fibers, like this type of preparation and different approaches. Again, we see higher energy wasting in the fast loser muscle, the responsive muscle. And then really interestingly, if we take the primary cells and grow them up in culture, weeks in culture, and determine mitochondrial respiration using seahorse technologies, again, we still see these differences. So a cell autonomous increase in energy wastage, if you like, but there are physiological mechanisms for that we can talk about, so it's preserved in cells in culture. We've also seen that the individuals losing weight quickly include distinct muscle metabolome and lipidome, and distinct even plasma transcriptome before the individuals enter the dietary program. It's predictive of how they respond, as well as interesting proteome responses as well. So, regardless, weight loss can, of course, significantly improve glucose tolerance, insulin sensitivity, and overall health. But regardless of the intervention method, whether it's diet, pharmacotherapy, or bariatric surgery, skeletal muscle loss is a common consequence. And you can see on the left-hand side there the change from initial skeletal muscle mass associated with the weight loss in the STEP 1 and SURMOUNT trials. So 8 to 10% of initial skeletal muscle mass was lost in those studies. So why should we be concerned? There's improved metabolic health, but muscle mass decreases regardless of approach. Well, skeletal muscle loss can be detrimental to strength and stability, particularly in older adults. I'm looking forward to the talks from my colleagues here about sarcopenia and the effects in older adults. We've known for a very long time that skeletal muscle is the major site of postprandial glucose uptake, so it's very important for glucose homeostasis. It's a major contributor to whole body metabolic rate. Even at rest, it's responsible for about 20% of metabolic rate. And then, of course, that proportion goes up with movement and exercise. Importantly, and I want to spend a little bit of time on this, it seems that skeletal muscle protects against the metabolic adaptation, that is the decrease in metabolic rate that goes beyond that predicted by the loss of skeletal muscle, etc., with weight loss. So skeletal muscle appears to play a major role in this metabolic adaptation. And metabolic adaptation is sometimes also referred to as adaptive thermogenesis or metabolic suppression. So this contributes to that perfect physiological storm after weight is lost. The weight-reduced state is associated with an increased drive to eat and a decreased overall energy expenditure. So how important are these decreases? Well, research by Fothergill et al. After The Biggest Loser, this is work from Kevin Hall's group, showed a 19% decrease in resting energy expenditure, adjusted for body composition. And they interpret this, just like a lot of people do, that this decrease increases the propensity for weight regain. It's difficult to keep that weight off. More recent results from Martins et al. From work in Birmingham, Alabama, Barbara Gower's group and others, showed that it's a lower amount of decrease. And they estimate that there's a 3 to 7% decrease in resting energy expenditure. This was a study in women. And rather than saying that it increases the risk for weight regain, they interpret it as a greater difficulty in losing the weight in the first place, like slow losers, a non-responder type of phenotype. Now, a lot of really great work has been conducted in Michael Rosenbaum's and Rudy Leibel's group in New York. And they have looked at the decrease in total energy expenditure, and they show that there's 20 to 25% decrease in total energy expenditure. And they conclude that most of this decreased total energy expenditure is due to increased efficiency of skeletal muscle contraction. So this is analogous to a car getting better mileage on the highway, not at the stoplight, which is analogous to resting energy expenditure when a car would be at kind of the stoplight, and more relevant perhaps to what we see in the decreases in mitochondrial proton leak, which is more relevant in that state in cells and tissues, which we can talk about later if we want. And they interpret this increased efficiency as kind of consistent with the neurohormonal environment at that stage, consistent with the reduced thyroid hormone status and sympathetic nervous system activity that characterizes this weight-reduced state. So we could refer to high-quality weight loss as a high proportion of fat mass loss to skeletal muscle loss. And just before I go on to talk more about skeletal muscle, we should remember, of course, that not all types of adipose tissue are equal. Visceral fat seems to be a major culprit because it's higher in metabolic activity and has a greater impact on insulin resistance, inflammation, and cardiovascular risk. And you can see in the MRI on the right-hand side here, the pink visceral fat. And others also in the literature remind us that subcutaneous fat is also important. There have been papers showing that reductions in cell size in the subcutaneous, shown in blue in the MRI scan there, is associated with improved insulin sensitivity. We also know that ectopic lipids in tissues, organs outside of the adipose tissue depots themselves are important. So lipid droplets, mostly neutral lipids in muscle, the liver, like is shown in this image on the right-hand side here, and this is associated with metabolic dysfunction, and we know that moderate weight loss can decrease ectopic lipids and improve the metabolic health of various tissues where they're found. Now, most body composition measurement approaches rely on the two-compartment model, which is the body fat component, fat mass, and fat-free mass. And fat-free mass is made up of bone, water, organs, and skeletal muscle. It's obviously not synonymous with skeletal muscle content within the body. Skeletal muscle mass, very roughly, is about half of fat-free mass. But again, these are rough approximations. Now, another useful surrogate measure of total body skeletal muscle mass, for example, as measured by DEXA scans, is the appendicular lean mass, because the amount of skeletal muscle in the appendages represents about 75% of total body skeletal muscle mass. And so using equations, whether it's through DEXA or other approaches, appendicular lean mass is a good estimation. Now, this slide just shows some of the common methods that are used in clinical settings, and MRI, CT, and ultrasound at the bottom are used mostly in research. But most commonly in the clinical environment, it's bioimpedance analysis with perhaps some anthropometry, circumferences and skin folds and so forth. And then in some settings, you also have DEXA. Bioimpedance, of course, it's non-invasive, quick, cost-effective, but it's known to be influenced by hydration, less accurate in extremes, and can't distinguish between different types of fat and adipose tissues in the body. Anthropometry, of course, practical, low cost, but sometimes there are problems with accuracy and precision because of site inconsistencies, say, for example, the waist circumference. Now, dual energy X-ray absorptiometry, DEXA, is more precise and can assess differences in abdominal fat compartments, visceral versus subcutaneous, but unfortunately there's limited availability of it in many clinical settings, and it's associated with low radiation, similar to radiation associated with an X-ray. The most accurate and precise measurements might be through MRI and CT, but they're very expensive to purchase and to conduct. So the literature shows that DEXA is emerging as like the reference standard, not the gold standard for assessments of skeletal muscle mass, but further standardization is needed. So now on to the question of how much skeletal muscle is lost with weight loss. So there's this quarter fat-free mass rule that says that approximately the loss of fat-free mass is roughly 25% of total weight lost, so kind of depicted in this diagram at the top here, a quarter of the total weight loss, regardless of whether it's diet, surgery, or pharmacotherapy. And about half of that can be skeletal muscle loss. Now, more recent models estimate, this is work by Stephen Hamesfield and colleagues, estimate that per 10 kilos of weight loss in response to voluntary calorie restriction in the absence of structured exercise, in men 2 to 2.5 kilograms, women 1 to 1.5. And the differences between men and women are influenced, of course, by initial levels of skeletal muscle and differences between men and women. Now, it's really important to remember that severe energy restriction, regardless of approach, is associated with greater losses of skeletal muscle. And sarcopenic obesity, which we're going to hear much more about, is associated with lower muscle loss, again associated with the lower baseline values in those individuals. Now, with regard to incretin mimetics, the loss of muscle, the literature shows that the loss of muscle seems to be in line with other weight loss approaches, but again, severe energy restriction is associated with greater muscle losses. So again, I'm showing these values that I showed at the beginning of the talk, and it's just important to remember that these values here are changes from initial absolute values of skeletal muscle, not percentage of total weight loss. So now quickly moving on to genetic factors impacting treatment response. Much less is known about variable effects of genes on variable responses to therapies than genes associated with predisposition to obesity. And then even less is known about the genes impacting variable skeletal muscle loss in response to therapies. So what we do know is that there are over 400 BMI-associated loci that impact appetite, energy expenditure, and fat storage. And there are known SNPs associated with FTO and the melanocortin-4 receptor that are associated with weight loss. Now, in response to diet specifically, what's known about genes associated with response? Well, genome-wide SNPs are known to explain about 49% of the variance in weight loss. And our work confirmed that in another study and showed a SNP associated with the gamma-sarcoglycan gene in skeletal muscle, and that was associated with lower amounts of weight loss in our dietary program. Now, in response to Roux-en-Y gastric bypass, again, the work of Lee Kaplan and colleagues in Boston showed a locus near two genes, this polysylation enzyme gene and an organic anion transporter, and this was associated with greater weight loss. In regard to responses to pharmacotherapy, a very recent paper published in Cell Metabolism from Cipuentes et al. And shown on the right-hand side here shows that combining genetic modeling with satiation measurements can predict treatment outcomes. And we're going to hear more about this from subsequent speakers in this symposium. It's going to be very interesting to see how myostatin-related treatment responses are relevant to the known SNPs in myostatin in humans that are known to be associated with muscularity and athleticism. What about metabolic factors impacting treatment response? Well, we already talked about skeletal muscle metabolism as being important in establishing metabolic rate. and metabolic adaptation. And again, some of the neurohormonal factors that are thought to contribute to this include sympathetic nervous system tone, the thyroid axis, and various adipokines and myokines that are thought overall to affect muscle contractile efficiency, insulin sensitivity, and lipid metabolism. It's known that higher baseline levels of insulin resistance can predict less favorable weight loss outcomes. And again, our own work has shown that mitochondrial efficiency in muscle is associated with lower weight loss response in response to a dietary intervention program. Now, just to wrap up, these are just a couple of points, and others will cover this in their talks as well. What can we do about this? What can we do to prevent loss of skeletal muscle? Well, the literature shows that adequate dietary protein is important and generally in line with these values. These are the bariatric surgery guidelines. But the single most important factor seems to be the inclusion of resistance exercise in preserving weight loss during preserving muscle during weight loss. And the novel pharmacological approaches, we're going to hear about this from my colleagues here, and it's a very exciting area for future research. So just to summarize, high quality weight loss, a high proportion of fat mass to skeletal muscle loss. There are various complex genetic and metabolic factors. And the benefits of preserving skeletal muscle include, of course, strength and mobility. So muscle function is very important. Muscle insulin sensitivity, oxidative capacity of that muscle, and metabolic flexibility of that muscle for muscle metabolic health. And protection against metabolic adaptation during weight loss, either improving the capacity for weight loss or for preventing weight regain, or both. So thanks very much for your attention. I'd like to thank my laboratory at the University of Ottawa and my colleagues in Ottawa for this research. Thanks very much.
All right, the way this will work is everybody will present, and once everybody's done, they'll all come up to the front and you can ask your questions at that time. So next, I would like to introduce Dr. John Bastos, an Associate Professor of Geriatric Medicine and Nutrition at the University of North Carolina. He is an NIH-funded physician scientist who's board certified in geriatrics. He provides care in the outpatient and nursing home setting to older adults with obesity, multimorbidity, and frailty. His research focuses on the interplay between fat and muscle in older adults using large data sets and clinical trials with the goal of improving physical function in the setting of weight loss. He also focuses on methods relevant to understanding the heterogeneity of aging, and he's really recognized internationally for his work with obesity, sarcopenia, and sarcopenic obesity. As a fun fact, his last visit to the ADA was 15 years ago, and he now returns as a symposium speaker. So please join me in welcoming Dr. John Bastos. All right.
Thanks, Scott. Thanks so much, Lisa, and thank you very much to the organizers and to the Diabetes Journal for inviting me today. Okay, great. Let me go back there. Okay, so I'm a geriatrician by training, and this is a topic that I eat, live, and breathe, as I like to say, on a daily basis, and be able to apply research into clinical practice and back into clinical research. My funding, some patents that are related to sarcopenia and physical function, and a number of societies that I'm involved with. So definitions are really important, and I appreciated Dr. Harper's presentation that she was able to kind of clarify a number of definitions regarding body composition. So I want to clarify here, the term sarcopenia has evolved tremendously and considerably over the last 4 to 5 decades. It was first coined in 1988 by Irv Rosenberg at Tufts. And it really, when you break it down, it means flesh and loss of. And you can see there's been a number of consensus guidelines that have been published over the last number of decades. However, the definitions vary. and they've varied over the last number of decades. It's really caused a huge confusion, not only in terms of when we think of sarcopenia, is it just muscle mass? And what are the associations of the term sarcopenia with distal outcomes? So I want to bring to your attention, there is a global leadership initiative in sarcopenia that is ongoing, that is attempting to harmonize the definitions. This is a number of experts worldwide, and it's come to the conclusion that the term sarcopenia includes loss of muscle mass and strength it predominantly occurs as part of the aging process, but it can occur across the lifespan depending on physical different conditions. Muscle performance, functional measures, and I'll talk about this a little bit later, are outcomes. And we've recently published a position statement on that just in the last few months outlining this. So it's really demonstrated the importance not only of objective physical function, which again, I'll show you the data relevant to GLP-1 and incretin mimetic medications, but also the terminology and separating function from muscle quantity. And we're in the process of developing cut points that will hopefully be able to allow us to predict and be able to stratify patients. So I want to talk a little bit about what occurs over time and with the aging process. And this is a figure that's going to be in a review article in Diabetes, hopefully published very shortly. As one ages, there's a propensity to gain fat, and usually there's a redistribution of fat centrally, which is, as we heard, pro-inflammatory and the like. Also, there's a natural propensity to lose muscle mass and strength with aging. And this usually occurs, muscle mass and strength peak in the third to fourth decade of life. And then, I'm afraid, it's all downhill from there. But everybody has a given threshold. And there is this crosstalk between fat and muscle. When gains fat, leads to insulin resistance, reduced energy expenditure, but also when you lose muscle mass and strength, that occurs as well. We also need to be mindful as one ages, one's ability to synthesize protein and diminishes, and one's ability, the degradation of protein actually increases. So you need bigger bang for the buck when it comes to protein, and I'll talk about that a little bit later. But all this leads to significant metabolic dysfunction, changes in biology, and it often leads to ectopic fat deposition, which is extremely harmful. Now, in the lean state, you have a number of markers. I'm not going to read this slide here, but there is a homeostasis where there's a balance between fat and muscle, keeps things in check. In the state of obesity, what ends up happening, there's a perturbation in this, leading to increase in inflammatory response, affecting the muscle, and then causing almost a double inhibition, which then perpetuates a cycle. This is a vicious cycle that occurs as one gains fat mass, as one loses muscle, and throw an aging on top of that, you got a big mess. And this is what ends up occurring, and there's a huge number of biological changes. I put this up not to kind of go through it in great detail, but this is a study that myself and Dr. Villarreal published a few years ago, but it really nicely outlines the mechanisms and what stimulates, what inhibits in terms of the interplay between fat and muscle. And I encourage you to, if you want more details, to look at that. So I mentioned that fat increases with aging, muscle mass and muscle strength diminish with aging. The Health ABC study actually demonstrated, and this is over a short-term follow-up, that even in individuals who lost weight over a 5-year period of time still gained intramuscular adipose tissue. And those who gained weight gained even more intramuscular adipose tissue. And this is when you have fat in the muscle, that actually leads to a huge detriment, and I'll show you a slide in a minute. Put it in another way, this is an epidemiological study, the Inchiante study, that looked at obesity defined using body mass index and strength, and looked at persistent mobility disability. Those with obesity and low muscle strength actually had faster declines in walking speed. Gait speed is a marker of physical function and performance, and actually had a higher risk of probability of mobility disability compared to either obesity alone, or in this study they termed sarcopenia as low strength, so be mindful of that. But there's a synergistic increase in worse outcomes with both obesity and low muscle strength. So the so what question, I always like to ask, so what? Why should we care about this? Picture's 1,000 words. This is an MRI image, as you can see here, cross-sectional of a quadricep muscle. The hyperintense signal is characteristic of intramuscular fat. On the right, this is a person without obesity, whereas you can see there's still a hyperintense signal. It is normal to have a little bit of intramuscular fat, but not to the degree that's on the left. I was lucky with my research group. We've published a series of epidemiologically based studies looking at both low muscle mass and low muscle strength, low muscle mass and low muscle strength, and impact on distal outcomes. And you can see, irrespective of the definition, individuals are at risk for functional impairments, falls, which is a major public health concern, particularly in older adults, mortality, reduction in quality of life, and most recently we've published an article that demonstrated that sarcopenic obesity actually leads to an increased risk of cognitive impairment. Now, the definitions are all over the place, and this is really important. This is an older study. We did a systematic review looking at definitions of sarcopenic obesity, and they ranged 18-fold. So that's a big problem from a scientific standpoint, and then being able to translate this into clinical practice is even more of a challenge. So I bring to your attention that the European Society for Parenteral and Enteral Nutrition and European Association for Study of Obesity, we have a consortium, an international consortium that is trying to harmonize the definitions, both at a screening level using body mass index and waist circumference, and clinical suspicion of sarcopenia, and then that will prompt a diagnosis of sarcopenic obesity. There are a number of international consortia, and we're in the process of trying to harmonize these definitions. So just to be aware that this is ongoing. So I want to pivot a little bit here to the crux of the talk. Is all weight loss the same? We heard this, that it's not the same. When you lose weight, you lose both fat mass and fat-free mass. So this image here is one where I want to walk you through this. We know that as individuals gain weight, your physical function diminishes. You gain weight, you develop obesity-related complications. We know from some of the formative randomized control behavioral lifestyle trials of diet and exercise that loss of weight leads to some resolution of obesity-related complications and improvements in physical function. I'm laying the foundation here for the incretin mimetics, where we know we are losing a significant amount of weight, but what's the sweet spot? We don't know yet. And I'm going to show you some of the data that is currently available. So just in the old adage in geriatrics, just because you can doesn't mean you should. You need to figure out what is the sweet spot and individualized for the given patient. This is some data that Dr. Villarreal published that demonstrated that aerobic and resistant exercise in combination with a dietary intervention still did lead to some loss of lean mass measured using DEXA, but importantly, both physical function and strength improved significantly. So you can lose weight, you can lose some lean mass, and still have improvements in physical function. How about with bariatric surgery? Significantly more weight loss. In this study, the proportion of lean mass loss was quite high. In laparoscopic Roux-en-Y gastric bypass, 53% of the weight lost was lean mass. Sleeve gastrectomy was a little lower. So we need to be mindful. When you're losing weight, you're losing a significant amount of lean mass. We've all seen these figures from Wilding's and Jastroboff's formative semaglutide and tirzepatide studies, which demonstrate significant loss of weight, and the panel on the left demonstrates that when one stops the medication, there is weight regain. And this has significant implications, and I want you to hold that thought. So as a geriatrician, I'm always thinking about, well, are these medications safe, effective in older adults? And my tune has changed over the years. And I will provide some, at least clinical, whatever my expert clinical guidance is a little bit in a few minutes. But what I want to bring to your attention is that the number of studies in older adults, I use the cut point of 65 and up as an older adult, is the efficacy of these medications is a little lower, as evidence here in the HepFef trial with semaglutide. Mean age was 69. Quality of life improved as evidenced by the Kansas City Cardiomyopathy and Clinical Care Questionnaire. Importantly, performance measure used in this study was a 6-minute walk test. 6-minute walk test is a measure of maximal aerobic capacity. Is it one that we use as part of our performance measures? Yes. Is it probably optimal as a marker of muscle function? That can remain debated. That said, while statistically significant, you can see the difference was 14.3 meters. That in some, depending on what you term and what you consider minimally important difference, either falls on the low end or may not be clinically significant. So again, we need more studies, and particularly in the aging population. When we think about body composition, these are some representation from the STEP 1 sub-study. We saw this. About 40% of the weight loss that was lost was lean body mass or fat-free mass using DEXA. That said, the SURMOUNT-1 study, and I want to walk you through this slide because this is really important. When we talk about weight loss, we think about it as a bucket of 100%, and this was alluded to in the previous talk. So one will lose fat mass, and hence, when fat mass drops, the percentage of fat-free mass will increase. But we want to look at the absolute degree and the absolute quantity of fat-free mass that's lost. And in this study here, 23 kilograms of individual was weight loss. Of that, 6 kilograms was fat-free mass. And as we heard, about 50% of that is muscle. And 17 was fat mass. That's a lot, and particularly in older adults. And this is where I get a little bit edgy in the sense that it makes you pause and say, are the medications, they're effective, but is it for everybody? Key thing here, only 6% of this cohort was over the age of 65. So again, jury's a bit out. But 6 kilograms of fat-free mass loss amounts to 10 years of skeletal muscle aging. And I think that's something that we would need to be thinking about. Where are the individuals on this trajectory on this sarcopenia trajectory? Because if they fall below a given threshold, that could be a problem. They may lead to frailty and disability. And I've actually seen that in my clinical practice. So you want to be mindful of that. SURMOUNT actually had an age sub-analysis. And the authors concluded that there were no differences by age. This has recently came out in the last 2-3 months. However, if you remember in the previous slide, 6% of the cohort was over the age of 65. And you can see here, 14 participants were over the age of 65 in the intervention group, and 6 were in the control. I always say sample size is a little low. I probably wouldn't make too many extrapolations from that. And there was a sub-study that was again published most recently that looked at MRI. It was an MRI sub-study. I thought this was a really interesting because it actually was the first one that looked at changes in intramuscular fat infiltration, and it was consistent. There were reductions in intramuscular fat across the age spectrum. However, muscle volume, and they assessed this using a given Z-score, was lower there's a higher degree of muscle volume loss in those over the age of 65. So again, we need more data, but it is promising that these incretin mimetics reduce the degree of intramuscular fatty infiltration. But what happens to muscle volume and whether or not that has an impact of function is unclear. So I'm all about physical function, day in and day out. However, this was a systematic review meta-analysis that really demonstrated improvements in patient-reported outcomes, so subjective physical function. We know subjectively patients feel better on these medications, and I think that's clear. But what happens, we know that there is about a 30 to 50%, depending on the study, discontinuation rate. We know as one loses weight, one's appetite diminishes, body weight decreases, changes in energy expenditure occur. But if one stops the medication for whatever reason, there is a rebound in weight, leading to increase in appetite, increase in energy intake, and there's actually a potential reduction in energy expenditure. And the reason for that is there's proportionally, without concomitant adjuvant therapies, an increase in fat mass relative to fat-free mass. And this hasn't been evaluated with the GLP-1s yet, but my friend and colleague Kristen Beavers at Wake Forest actually did a study where in postmenopausal women, after a 5-month RCT for weight loss, actually found for every 1 kilogram of fat loss during the weight loss, 0.26 kilograms of lean mass was lost, which aligns with the quarter mass rule. But subsequent to the intervention, they measured 12-month follow-up of body composition at 12 months after the intervention. For every 1 kilogram of fat regained, only 0.12 was lean mass. So really, from a lifestyle standpoint, and again, we're extrapolating this to the GLP-1s, we do not have data for after discontinuation, to my knowledge. So when you're treating the patient, you need to balance muscle and fat. There is heterogeneity. Everybody's going to respond differently. There are people that are going to benefit. There are people that are not going to benefit. Older adults have higher rates of adverse side effects as a result of these medications. So it's something you need to be mindful of. The start low, go slow. Always trying to achieve patient-specific goals. Lifestyle is the foundation. An interprofessional team, I've heard this in a few talks. I was glad to hear this. This is really about not only a provider, we need an interprofessional team to be able to care for our patients. These are some, I'm not going to go into the detail, some recommendations in terms of dietary changes that should be considered as part of a multidisciplinary team approach. I'm not going to talk about exercise because I believe that's going to be discussed a little bit later. We talk about high protein intake. The data is not as clear as we would like it to be. This is one systematic review and meta-analysis. It looks like high protein supplementation is likely going to be helpful. And we recommend 1.2 to 1.4 kilograms, grams of protein per kilogram per day, spread throughout the day. So patient eligibility, this is from an older adult standpoint. I generally recommend 65 to 85 because the epidemiological data on intentional weight loss after the age of 85 is limited. There has to be an interprofessional team-based approach that highlights patient-centered care. Make sure they're off obesogenic medications and ensure that they're already doing what they're supposed to be doing. Comprehensive lifestyle interventions are, in my mind, mandatory as part of treatment care. But where are they on the sarcopenia trajectory? That's harder to ascertain. So thinking about ongoing monitoring, if I were able to conduct a DEXA on everybody, I would. Unfortunately, there are regulatory barriers and practical barriers to that. But what you can do in your office setting are objective assessments of physical performance measures. Look at the rate of weight loss. Maybe some individuals may need a little bit more evaluation on a regular basis. and be mindful of costs and polypharmacy. Start low, go slow, and monitor for symptoms. And with that, I want to thank you for your time.
Thank you so much. Next, we have Dr. Paul Tichenel, who is the Executive Director for Metabolic Physiology at Eli Lilly. Prior to that position, he was an associate professor at the University of Pennsylvania in physiology, where he directed the rodent metabolic phenotyping core. His research has primarily focused on the regulators of hepatic lipid and glucose signaling, with recent expansion into muscle energetics and muscle preservation. Currently, he is interested in identification, development, and mechanistic understanding of new therapies for cardiometabolic disease. One thing about Paul is he did not provide me his biography, so I had to dig through the internet. And when you dig through the internet, you find fun facts. And the fun fact on him is that when he was in high school and college, he worked at GNC. He read a lot of Men's Health. He was inspired by the supplements, and that inspired his love for physiology. And it came full circle when he was featured in Men's Health recently. So please join me in welcoming the star of Men's Health as our symposium speaker today.
Wow, that was terrific. I'm just so thrilled that that's what the search came up with and nothing else. So, wow, I thanks to Google and ChatGPT. So, thank you to the organizers for the opportunity to present. I will be focusing exclusively on academic work that I conducted at UPenn. Here's an obligatory conflict of interest slide. I'm now at Eli Lilly. Nothing that I will present was performed by Lilly nor endorsed. This is my own thoughts and views. What we're going to focus on is a little bit of a shift. I pretty much should skip, honestly, the first 5 slides. This is the benefit of going third after 2 fantastic clinician talks. But we're going to really change gears and look at preclinical mouse models, trying to get some of the mechanistic insight to a lot of these questions that were very nicely introduced a couple moments ago, and thinking about ways pharmacologically we can manipulate the system to lead to benefits on body composition. So I'm going to go really quickly, given that I'm third and this was already really presented. We know we are in the golden age of really effective weight loss therapeutics that lead to profound body weight regulation. It was very nicely introduced that the effects on body composition following weight loss, this is just a clear example of the quarter rule that was introduced. Obviously, fortunately for many of us, when you lose lean mass, it's not from your brain going through bouts of weight loss. It comes from other metabolic tissues and your skeletal muscle. If you quantify this is data from Eric Ravison at Pennington. Resting energy expenditure is reduced by 13 kcals per day for every kilo of muscle that you lose. So cumulatively, there's a significant impact of losing skeletal muscle. And again, I really should just skip ahead, but this was the same slide that was presented a moment ago. I guess don't want to really take the viewpoint at all from a negative side effect point of view. Rather, the opportunity now that we have highly efficacious GLP-1 and other weight loss therapeutics, what we can do better and in the future to really enhance the weight loss quality, and there's opportunities, I think, for us to make an impact. So I would just say at least that when we lose weight with GLP-1s, it's as great or potentially greater, but most of the data is really coming online saying it's really what you would predict from the equivalent caloric restriction, right around 25%. When we think about fat mass, we all know that's associated with overall mortality and morbidity, and we commonly see these classic J-shaped curves. When you have very low fat mass, that's associated with an increased hazard ratio of mortality, right? Lipid dystrophy, we need some adipose tissue to be overall healthy, but there's an exponential increase as you gain fat mass. What's important to also think about is fat-free mass is just as important. It's almost quantifiably as an independent variable to predict mortality. So again, it's just the opposite, right? Really low fat-free mass is also associated with an increase in mortality, and the opposite is certainly true. Using creatine dilution methods to quantify muscle mass and associated with muscle strength clearly shows that lower muscle mass is associated with decreased muscle strength and fitness. So again, we know muscle is important for both of those. And as already brought forward, we could think about what really is leading to this plateau phase. There's many hypotheses. One hypothesis is that the reduction in muscle mass, and the reduction in energetics leads to a sort of plateau in this weight loss. And if we can modify body composition in a positive way to enhance fat loss and increase muscle mass, we may either have sustainable weight loss or combat the energetic decline that happens. And as was very nicely brought forward, we have no data clinically that I'm aware of that looks at body composition in the cessation of GLP-1 therapy. We do have mouse data, and I will share that with you in a second, but it's mouse data. Okay. So the data that I do as a physiologist, one of my favorite experiments that I love is classic Minnesota starvation experiment. And this is data that kind of suggests what extreme bouts of starvation can do to energetics and body composition. This was done in World War II era when looking at the effects on different macronutrient dietary models to see how do we rebuild weight following extreme bouts of starvation. This is clearly more severe than what current pharmacotherapies give you, but it gives us a really well-controlled study that you probably could not do in 2025. But nonetheless, we have the data from 75 years ago, like so many other examples. And here is the data from this. So it's a sort of complicated graph, but I'll walk through it. And on the left is just the baseline values for period of starvation going from really extreme 50% reduction in caloric intake, and that you see that monitored here. And then the closed circles is fat-free mass, and the open circles is fat mass. And again, in 12 weeks, you lose significant fat mass, you lose fat-free mass, right almost exactly to that quarter rule, 25% fat-free mass, 75% fat mass. When the individuals were allowed to have ad libitum access to food, obviously they're hyperphagic, they're quickly regaining weight, body weight. But the interesting period here is that you can see the clear differences in the slope of the line in terms of the body compartment. And in the sense that the slope, obviously, the fat mass gain is much steeper than fat-free mass. And even there's a period of time that fat mass clearly overshoots from a baseline standpoint. So again, at least initially, we have very limited data how far this goes out, but initially, from a body composition point of view, you're more biased towards fat than muscle from when you started going through an extreme bout of weight loss and weight cycling. And if we just look at individuals that have gone through bouts of cycling and looking at the effects on muscle mass and grip strength, you can see multiple bouts of weight cycling leads to a decrease in muscle mass, associated decrease in grip strength, and an increase in sarcopenia. This is convoluted, obviously, because aging is part of this variable, so we don't really know the relative impact of this. But what my job was when I was at Penn is to use mouse models, preclinical mouse models, to really try to be reductionistic and understand the relative contribution to weight loss and incretins on body composition, and then look at the activin myostatin pathway as a potential modifier of that based on years and years of clinical data. So the first question we asked was quite simply, how does cessation of GLP-1s influence body composition regain in a mouse model? And that's a diet-induced obese mouse model that is commonly used in the laboratory for preclinical studies. Very simple study, take a very 25-week-old diet-obese mice and gave very long semaglutide injections for 10 weeks. This is an extreme amount of work, frankly, for the core, but also for in terms of modeling this study in rodents. And if you do that and you then follow them for 10 weeks, you can see, so you have this very robust change in body weight that occurs with GLP-1s in animals that's reproducible, very significant decrease in fat mass, a decrease in lean mass. And then as you get out to about 10 weeks, cessation of therapy, you can see the slopes of these recoveries are quite different, at least initially. So again, initially, in animals, long-term GLP-1 receptor agonism treatment leads to a biased accumulation of fat compared to lean mass. This is really long treatment paradigm. This is in mice, but these are the data that we've generated preclinically. And so, you know, like many of us, we're thinking about quality of weight loss. And if you're from Philadelphia, you want to stand on Broad Street here and take an obligatory photo with City Hall behind you. And you want to be like Rocky, so you wear your fedora and your Chuck Taylors. But this is what happens when you use Microsoft Designer for AI generated images. It can really go down a rabbit hole, but this was fun with my kids, so we do it all the time. But so we think about increasing functional, metabolic, and energetic benefits. Muscle's important, not just from a strength point of view, but from a metabolic point of view. And can we really lead to and contribute to a new frontier of weight loss therapeutics? And maybe there's particular applications, as we just heard, in individuals that may be more susceptible to deleterious effects on muscle mass. Okay. So we're going to focus on the myostatin activin pathway as a major regulator of muscle hypertrophy and mass. This was really pioneered 25 years ago by the seminal discovery by Se-Jin Lee that identified GDF8 or myostatin as a potent negative regulator of muscle growth. And you can see animals that are devoid of GDF8 have extreme muscle hypertrophy and really no fat accumulation. Myostatin and another TGF-beta ligand, activin A, signal through these receptor complexes called the activin receptors. There's type 1 receptors, ALKs 4, 5, and 7 in adipocytes, but in muscle 4 and 5, and the type 2 receptors, which will be important in a moment, ACVR2A and 2B. These are important receptor complexes that heterodimerize, lead to the activation of SMAD signaling, and then the control of muscle hypertrophy and differentiation. We'll explore some of this mechanistically in the second half of the talk. As an academic at that point, we were really just looking for models that we could use to exploit this pathway, given years and years of preclinical and clinical data, really highlighting the efficacy of this approach to control muscle mass and fat mass in humans. And one exciting study that I'll just highlight in a moment was this antibody called bimagrumab, which is a dual-specific ACVR2A, 2B monoclonal antibody that's targeted to the type 2 receptors that thus prevents myostatin and activin A signaling, binds in a similar region to activin A. Data that was really put forward in the 2017 started arguing that there was functional redundancy between the type 2 receptors and that you needed approaches to inhibit both type 2 receptors to have maximal effects and efficacy on muscle mass. And so just to walk through these data, you can see either ActR2A antibodies, sorry about that, low or high dose, really had minimal effects on muscle mass, maybe a little bit more in the quadricep for 2A. ACT2B, again, very minimal amounts on the gastrocnemius or quadricep, but clearly combining these two monoclonal antibodies or having a dual-specific antibody leads to profound muscle effects in preclinical models. There was an exciting study that was published in 2021 looking at bimagrumab, this activin type 2 receptor antibody in obese and overweight individuals, phase 2, 48-week study. And what I did here is just took the efficacy data and put it on top of the early step 1 body composition extension that I showed before. And you can see, obviously, from a weight loss point of view, it leads to significant weight loss, albeit nowhere near the extent of a GLP-1, but the weight is coming exclusively from adipose tissue. So all of the weight is lost, almost comparably to a GLP-1, and yet there's lean mass preservation. And at the end of the study, if you look it was a 48-week study, if you look 12 weeks out, body weight and fat mass was still sort of somewhat reduced. So as an academic at that point, I was fortunate that these were commercially available, so we were able to get our hands on this tool to study its physiology in animal models. This was spearheaded by a very talented graduate student at UPenn, Libby Nunn, who did a really quite simple experiment where they treated obese mice either with once a week bimagrumab, 20 mg per kg, or daily semaglutide injections, and did a host of metabolic readouts. I'm going to just focus on some of the body composition data in a moment. Semaglutide is very potent, reducing body weight at room temperature. If you add on bimagrumab, you really have no additional body weight effects. Maybe a trend, but no additional, at least in our hands, no additional body weight effects, either alone or with on top of a GLP-1 receptor agonist. This, as I should know, this was all published early last year. The key question, though, was what happens to body composition. So we did echo MRIs at baseline 7 and 13 days. And you can see bimagrumab leads to a significant reduction in fat mass. The placebo is declining a little bit. This is unfortunately what happens in rodents when they're getting daily injected with a placebo saline control. So they do get a little bit stressed out. Semaglutide gives a little bit more fat loss, but excitingly, the combination gives an additive effect on fat loss. Just told you body weight was the same, so it must be coming from the other compartment. And again, ActR2 inhibition in preclinical models leads to about 8 to 9% increase in lean mass. And at the 2-week time point, there was no significant difference from a control. So in this model, in this preclinical mouse model, all of the weight, this is equivalent weight loss for semaglutide, was the same as semaglutide, but exclusively from the fat, no lean mass loss. I will mention these are at room temperature, so some of these studies could be slightly different in terms of the energetic components, given if they're at room thermoneutrality or et cetera, and that may or may impact total body weight loss given these relative agents in thermally stressed animals, for what it's worth. This is just confirmatory, looking at fat loss and all that's additive, just like the echo suggests, and here's tibialis muscle, just consistent with the echo data that I just showed you a moment ago, and multiple metabolic parameters. I'm just, again, highlighting some of the high-level ones. Leptin's a really good readout of fat mass, and you can just see it's really robustly decreased in the combination group. So the next question we talk a little bit about is muscle function. Myostatin activin pathway has been around for quite a long time, related to function, and other models like Duchenne's and other approaches really did not show much of a functional benefit despite increases in muscle mass. It's a completely different paradigm, obviously, but it's important to know what happens to muscle function. And here I'm defining muscle function as strength, but as a metabolic researcher, you can also think about it, energetics, et cetera. I'm not going to focus on that for the rest of the talk. So you can do a simple experiment in mice. You can do grip strength, and if you treat obese mice with bimagrumab, you have a potent increase in grip strength, commensurate with the increase in muscle mass. We like to do a VO2 max protocol in preclinical models. It's obviously a integrated response that looks at multiple parameters, including skeletal muscle function, but it's a good, I think, functional readout of what could translate in terms of clinical outcomes. And when you treat with an ActRII inhibitor in obese mice, you have about 20% increase in VO2 max, which for any athletes in the room, a 20% increase, again, it's in animals, but a 20% increase in VO2 max is quite a significant increase in a VO2 max. This is largely, we think, accounted for the increase in muscle. So if you do an ANCOVA analysis and look as muscle as a covariate, it really accounts for this increase, at least under these conditions. And then before I transition mechanistically, what about the adipose tissue? And clearly bimagrumab causes robust morphological changes in the adipose tissue. In vivo increases, just high-level thermogenic gene signature, but it seems to be somewhat cell autonomous. You can recapitulate that effect in isolated in vitro cells. You can put ActRII inhibitors and turn on the thermogenic gene program. And using metabolic labeling, here's just a C13 tracing study in the lab where we infuse palmitate and look at palmitate turnover as a direct readout of fatty acid turnover, so FCIRC, and you can see about a 30% increase in FCIRC on the 5-hour fasted animals. This is really a direct readout of lipolysis, but you can see in the refed state and high insulin, there's still higher fatty acids, again, consistent with an increase in lipolysis despite hyperinsulinemia. So it seems likely that ActRII inhibitors are increasing lipolysis, at least preclinically in vivo. So from the conclusions from this part, obese mice treated with activin receptor antibodies induces muscle hypertrophy and fat loss, and there are some direct effects on adipose tissue. So many ongoing phase 2 studies, but I think many of us, hopefully in the audience, know that Monday the BELIEVE trial will be released here at the ADA, and we'll see obviously the data from the phase 2 study looking at in combination with semaglutide and as a monotherapy. That'll be Monday morning. Okay, and for the last 3 or 4 minutes, I just want to focus on mechanistically how this may work. That was a focus of my academic lab. For many years, the way SMADs were thought to influence muscle hypertrophy was through the AKT pathway. And so if you treat cells in culture with myostatin, you increase SMAD and you decrease AKT phosphorylation. You can block that with an ActRII inhibitor. You see this increase in AKT phosphorylation. AKT is an important serine threonine kinase that sits downstream of the insulin and IGF receptor, and it's been thought to be involved in protein synthesis and proliferation. I'm going to show you a couple of those in a moment, and our lab contributed to some of that. But work by David Glass, Ken Walsh, and others have shown constitutive activation of AKT in the skeletal muscle leads to profound muscle hypertrophy, a lot similar to the myostatin null animal, and a significant increase in the cross-sectional area. My lab has spent about 5 years doing the opposite experiment and asking the question, is AKT required for muscle hypertrophy, and specifically what isoforms are important? So I had a very talented postdoc who now has her own lab at Purdue University, and Tasha Joswal, generated every flavor of AKT skeletal muscle knockouts, 1, 2, in combination, inducible, congenital, and looked at the effects on muscle mass. Just to summarize 5 years of work really in 2 slides, the combined knockout of AKT leads to significant muscle atrophy. So AKT is required and sufficient in skeletal muscles to control growth, and that's associated with muscle weakness and inability to run. They have half the muscle. And then in cells, in ex vivo systems, we can do ex vivo physiology, and you can look at force production in EDL, fast twitch muscle, or soleus muscle. And in the EDL muscle, absolute force is down, but once you normalize the specific force, it really normalizes out. Soleus muscle looks like there's still an intrinsic decrease in muscle strength, and that may be related to oxidative effects, which I'll highlight in a second. Muscle mass loss is due to a decrease in protein synthesis. This is metabolic labeling with heavy water, looking at the fractional synthesis rate. It shows it's significantly decreased with no effects in proteolysis. So at least in the AKT knockout, it's the decrease in muscle mass is due to a decrease in synthesis, not an increase in degradation, at least at steady state. Some of the things we really like to do academically is genetic epistasis experiments, and so we make combinatorial knockouts to try to recapitulate what's downstream and what's either in the same pathway or other pathways. So we look famously at the two downstream pathways, or the mTOR pathway and FOXO pathway. We generated triple knockout animals to isolate the effect on mTOR or FOXO by knocking out AKT and TSC, the negative regulator of TOR, or FOXO1. Makes individual knockouts. Both of those were not sufficient. Don't take pictures of this slide because it didn't do anything. It was a null phenotype. But maybe this next slide, it's published, but you can certainly take a picture. Get me in there if you want. But individually, there was no effects by either activating TOR or inhibiting FOXO simultaneously alone. But if we did the experiment and you do both, and there's some data that the FOXO is more acting as a transcriptional repressor in this model. If you do both, you actually can completely restore muscle mass in the absence of AKT. So this animal has no AKT in the muscle, yet their muscle was 30% bigger. And it's obviously much more red. Cross-sectional area is much larger, so bigger fibers, increase in protein synthesis. That also was associated with the normalization of this really extreme oxidative phenotype. You see really from an ultrastructural level, really disoriented mitochondria. The cristae structure is disoriented and fragmented. And in using high-capacity respirometry in isolated mitos, you can see AKT knockout leads to defective respiration. That's completely normalized by combined regulation of TOR and FOXO. Okay, very long-winded, and I only have 1 minute. The reason we did this experiment is the reason I walked you through all that data was then to do this simple experiment, was that if activin inhibition controls SMAD phosphorylation, how SMADs work is through AKT. We should take advantage of our AKT models, which don't have AKT, and we should treat with myostatin or activin A blockers, and that should prevent the phenotype, right? In terms of muscle hypertrophy. Very simple experiment. So you have no gain in muscle mass. I wouldn't be showing you unless it was some unpredicted response. And the fact that when we did the experiment, we maybe saw a 2 to 3% some of these muscles, but overwhelmingly, majority of the effect of ActRII inhibitors to drive muscle hypertrophy was intact in a muscle that was completely devoid of AKT. This is all AKT isoforms. There's no activation of at least insulin-mediated downstream signaling or IGF-mediated. Okay, so there has to be AKT-independent pathways that mediate the effects of ActRII inhibitors to promote hypertrophy. Interestingly, mTORC1 activity was activated in these muscles without AKT. So I think many of us know that mTOR can be controlled by both growth factors and amino acid sensing. So what these data really suggest to us is that maybe mTOR is involved. It can be activated without AKT, either in vivo or ex vivo, and that somehow activin pathway, maybe through SMADs, is controlling that nutrient sensing arm of mTOR, independent of AKT. More data would needed really to be to prove that mechanistically. Okay, with that, especially thank the lab and the NIH for funding all of this work. Special shout out to Libby, who's a graduate student, and Natasha. Some of this work was supported by the RMPC at Penn. Corey Holman is here if you're interested in doing studies at Penn. It's a great core. So thank you.
So our last speaker of the day is Dr. Dennis Villarreal from the Baylor College of Medicine, where he's a professor of medicine. He's board certified in both geriatrics and endocrinology. His research focuses on hormonal, nutritional, and lifestyle interventions aimed at either slowing or reversing the metabolic and physical complications of aging, including sarcopenic obesity and type 2 diabetes. He has received the Michael DeBakey Excellence in Research Award from the Baylor College of Medicine in 2020 and a Physician Enterprise Vision Award from the Common Sprint Health Research Institute in 2024. Well, as a fun fact, for anyone who's interested in staying as young as possible for as long as possible, this is his area of research, and he will have office hours after this session. So please join me in welcoming Dr. Dennis Vieira.
Thank you, Dr. Crow, for the kind introduction, and it's a pleasure to be here and to present a talk on the benefits of exercise training in combination with weight loss therapies. Here's my disclosure. So these are the topics I'm going to cover. Current trends in obesity among older adults, current obesity treatment approaches, and the added benefit of exercise when combined with weight loss therapies. Although well known, it's worth stating briefly that obesity is defined as abnormal or excessive fat accumulation that plays a central role in the development and progression of many chronic diseases, and these include hypertension, diabetes, stroke, and cancer. Obesity is a rapidly growing public health issue, and according to the World Health Organization, more than 40% of adults in the United States are currently obese. What is particularly concerning is the sharp increase in older adults. In just one generation, the prevalence of obesity in adults 65 years and older has nearly doubled, increasing from 22% to 40%. These are the current treatment strategies for obesity, and these include lifestyle interventions, either through caloric restriction with regular exercise, bariatric surgery, or pharmacologic therapies. But these approaches, especially caloric restriction, come with important limitations. Caloric restriction-induced weight loss is associated with progressive decline in lean mass and bone mineral density, and this may be of particular concern in older adults, given that they are already at risk for sarcopenia and osteoporosis, both of which can be exacerbated by weight loss. So in this study, we directly compare the effects of aerobic training, resistance training, and their combination in 160 older adults with obesity undergoing caloric restriction. Our goal was to determine which approach best preserved muscle and bone mass while improving physical function during weight loss. As shown here, each group achieved about 10% weight loss, allowing us to isolate the impact of the different exercise modalities. We found that despite being in a negative energy balance, aerobic training improved cardiorespiratory fitness, while resistance training increased strength. And importantly, the combination improved fitness and strength to the same extent as each exercise alone. And these additive effects translated into the greatest gains in physical function and reduction in frailty. What is this? Okay. I'm just going to use this one. Both resistance and combined training mitigated the lean mass loss seen with aerobic training alone. And while only resistance training fully preserved hip bone mineral density, the combination approach still significantly attenuated the bone loss. We recently demonstrated that while all exercise modalities similarly reduced subcutaneous fat in the abdomen and the thigh, combining aerobic and resistance training was most effective at reducing ectopic fat, specifically visceral and intermuscular fat. And these reductions were accompanied by the greatest improvement in insulin sensitivity. To understand how muscle mass was preserved during the intervention, we measured the rate of muscle protein synthesis using stable isotope tracers during fasting and after a mixed meal. We found that the anabolic response to feeding was significantly greater in both the resistance and combined exercise groups compared to the control. We found that resistance and combined training preserved expression of genes promoting myogenesis, while combined training also reduced autophagy markers. Aerobic training increased mitochondrial activity and upregulated key enzymes involved in the citric acid cycle and electron transport chain. Furthermore, we found that compared to the aerobic group, the relative preservation of bone mineral density in the resistance and combined exercise groups was associated with a smaller weight loss-induced increase in CTX and P1NP, both markers of bone turnover. In this earlier study of 107 older adults with obesity, we found that combining diet and exercise produced the largest gains in physical function. Importantly, changes in thigh muscle volume measured by MRI paralleled the changes in hip BMD measured by DEXA, suggesting a well-coordinated muscle-bone response to weight loss therapy. In this trial, participants were randomized to diet alone or diet plus resistance training for 6 months. We found that resistance training reduced fat-free mass loss by half, nearly preserved upper extremity lean mass, and increased lower body strength by 20%. Importantly, the amount of training volume strongly correlated with the lean mass preservation, supporting a clear dose-response relationship between exercise training and the preservation of lean mass during weight loss. In the Infinite trial, all 180 older adults with obesity performed aerobic exercise at moderate intensity. Adding either a moderate or intensive level of caloric restriction led to a greater improvements in fitness, disability, and fatigue compared to exercise alone. Now let's shift to another commonly used strategy, bariatric surgery. Bariatric surgery, as we know, reduces major cardiovascular events and often resolves obesity-related conditions like diabetes, hypertension, and sleep apnea. As shown here, it leads to substantial fat mass loss, around 34%, including a 43% reduction in visceral fat. However, it also leads to a 20% loss in lean mass. While muscle strength appears to be maintained, this degree of lean mass loss may be concerning, particularly in older adults. In this meta-analysis of 23 studies with nearly 2,000 patients, combining bariatric surgery with exercise did not further reduce body weight, but it did lower fat mass, preserve lean mass, reduce waist circumference, improve VO2 max, and reduce mortality risk. So we know that lifestyle interventions are the standard first-line treatment for obesity, but long-term adherence is a major challenge. While bariatric surgery is effective, especially when combined with exercise, it remains underused and hasn't kept pace with the obesity epidemic. That's why there is growing interest in incretin-based therapies. They produce, as we know, significant weight loss and improve related conditions. But as the previous speakers indicated, they may also reduce lean mass. And if stopped, over half of the weight loss can return, mostly as fat. So here's what happens when we combine incretin-based therapies with exercise. In this study, 195 participants first completed an 8-week caloric restriction phase, resulting in marked weight loss. Then were randomized to placebo, exercise, liraglutide, or the combination of exercise and liraglutide for 1 year. The combination group saw the greatest reduction in body weight and fat mass while preserving lean mass. Cardiorespiratory fitness also improved, unlike liraglutide alone, which slightly reduced fitness compared to caloric restriction alone. In addition to effects on lean mass, this study also looked at changes in bone mineral density. Bone mineral density decreased in the liraglutide group at both the hip and the spine, but this was attenuated when exercise was added. No changes were observed at the distal forearm. So overall, it was concluded that a combination of a GLP-1RA with exercise was the most effective approach for weight loss while helping preserve both lean mass and bone density. So how do we actually apply this in the real world? You don't need any fancy equipment. Your body is a gym. Body weight exercises are a simple, accessible way to build strength, preserve muscle mass, and improve function, especially in older adults. This slide shows key movements: push-ups for upper body, squats and lunges for lower body, and planks for core stability. No gym required, just consistency. Aim for 3 to 4 sessions per week, focus on good form, and gradually increase reps or speed as you improve. So to wrap up, here are some key considerations when putting all of this into practice. Combining exercise with diet not only helps preserve muscle and bone during weight loss, but also boosts physical function, in part through increased muscle protein synthesis, improved muscle quality, and the skeletal loading effects of resistance exercise. That said, lifestyle strategies must be sustainable in the long term. Repeated cycles of weight loss and regain, which are common, can progressively reduce lean mass and bone mineral density. And finally, caution is warranted when prescribing incretin-based therapies to older adults, especially given the potential impact on bone and muscle. To summarize, calorie restriction, whether achieved through lifestyle change, surgery, or medication, can lead to loss of muscle and bone. Resistance training helps preserve lean mass by stimulating muscle protein synthesis even in a state of calorie deficit. And aerobic training improves cardiovascular fitness when added to a weight loss plan. Together, combining both exercise types with caloric restriction provides the greatest benefits for body composition, bone health, and physical function. Thank you.
Thank you. Want to take a seat? All right. With that, we'll have the four speakers come up. If people are interested, they can come up and ask questions. Please state your name and institution as you come up. Go ahead.
David Seymour from Emory and Grady in Atlanta. We primarily prescribe the incretins for diabetes, but weight loss often accompanies that. And while we refer people to dietitians and encourage aerobic exercise, we haven't really done much with resistance training. It sounds like the largest muscle groups for resistance are going to be the legs. For our group, where people are somewhat elderly, the average age is 55, doesn't sound like squats are going to be quite the safest thing for a lot of our folks who are extremely obese. Do you all have recommendations for resistance training when prescribing for diabetes?
A question for me? So exercise has to be individualized according to the patient's limitations. And like I said, any kind of exercise is better than none, right? You just want to keep the person active. And we've shown that they can exercise, and especially I'm talking about older adults where the concern for exacerbating sarcopenia and osteopenia are more important. And older adults appear to be more motivated in our experience because they don't have the commitments with families and they're often retired. And another way is to do the exercise as a group because they can motivate each other. And again, Dr. Bassett emphasized in his previous papers that Medicare does cover behavioral lifestyle therapy. It's just underutilized, but utilize it. You can use also, I recommend people to download a program. Can't prescribe any program, right? But there's a lot of applications there, like MyFitnessPal, for example, that they can monitor their steps, and they can also enter the amount of calories they're taking and motivate them to progress to successful weight loss and become physically active.
John, did you want to comment at all?
Yeah, I think the other thing, just to follow up on Dennis's comments here, you can medicalize the exercise program a little bit as well. Referral to physical therapy or local exercise physiologists who may be in wellness centers as well. There's a lot of community resources that even in under-resourced communities are there. It's just a matter of, one of the challenges that providers have is we don't know about them. So being aware of that, and that's why the importance of multidisciplinary team-based care. Again, start low, go slow, because but even technology-based methods, virtual classes, older adults can do that. That's been proven, and particularly post-pandemic, it's flourished.
Yeah, more than 50% of people on semaglutide eventually stop it, and you see weight regain and they regain the fat. So it's important that you do it concomitantly with lifestyle change, right?
So we'll just take the three people, and that will be it. So go ahead.
Thanks, Ken Addy, Eli Lilly. Unfairly, my question's a little bit to Paul, but my question's a little bit about muscle protein synthesis as well as protein degradation and sort of the balance between those pathways. You talked a lot about the muscle building pathway through AKT, mTOR, but there's also this FOXO pathway through ligases that somehow the SMAD2/3 signaling from myostatin and activin somehow cooperates with FOXO in that protein degradation pathway. And bimagrumab has been shown to be able to prevent muscle loss from protein deprivation in a very nice protein deprivation study that was done years ago. So I guess my question to you is, what do you feel is the relative importance of either, helping the AKT protein synthesis side of the equation or sort of blocking the FOXO degradation pathway when we block myostatin?
Thanks, Ken, for the question. I think it's maybe a cop out of a question or a response, but I think it's very contextualized. I think in the genetic data in animal models, without any perturbations, with a dexamethasone or a casting immobilization, we have no evidence that the atrogene pathway was activated. We looked transcriptionally, we did metabolic labeling. Under those conditions, it was protein synthesis, but it still required, FOXO was still involved because that's what the epistasis said. It just wasn't as simple as the canonical E3 ligase mechanism, but I think based on the AKT pathway, it's certainly FOXO dependent. We don't have a simple E3 MERF1 explanation for mediating that. I just will caution. I think without additional perturbations in rodents, that most of the atrogene pathway was really biased towards dexamethasone and immobilization and other assays. That's how they were identified, frankly. So I would just say under AKT deficient conditions, it's protein synthesis does not exclude relevance of antagonizing the atrophy pathways in other systems. Yeah, thanks, Ken, for the question.
Next question.
Everyone, Amin Shaherli from Point Health. Had a question. Would it be feasible to combine a GLP-1 with HRT or anabolic steroids to kind of not only, I guess, prevent muscle loss, but actually lead to muscle gain, perhaps an agent with a good anabolic to androgenic ratio?
So short answer is it may not be a great idea. There are risks with some of those agents. There are emerging meds, though, along those lines that have been used in cancer cachexia in the past. Enobosarm is one of them. And that might be something that may come to fruition. They in some older studies, in an older study, they actually in cancer cachexic patients demonstrated improvements in steer power in that cohort. And these are individuals, though, they had unintentional weight loss, which is obviously physiologically very different. So.
Can I just comment? We did a study of testosterone replacement therapy combined with weight loss therapy, and it could attenuate the loss of muscle and bone mass. So you can look at it in JCM.
Thank you so much.
Last question.
Thank you, Birgitte Ursø from Novo Nordisk. This is directed to you, Paul. So in the mouse, it's very clear that the 2A and the 2B receptor are equally important to block. Do you have any insights into the human setting? I mean, I'm sure bimagrumab will do both, so we'll cover that in the first round, but whether you actually need to block them both in the human setting.
Let me think about how to respond to this.
It was easier before you joined.
It was much easier to be. There's a couple interesting posters I saw in the poster hall that used some pharmacology that looked at the requirement of 2A and 2B. I think they're presenting tomorrow.
Okay, thank you.
Sorry for not.
With that, we conclude this session. Please join me in thanking the speakers.